And the next section, I invite Dr. Venkat for systemic emergencies in an ophthalmic setup.
Good morning to all of you. Let me first of all thank the organizers, ophthalmic organizers and our anesthesia organizers who have given me the opportunity to present this systemic emergencies in ophthalmic setup. I work at LV Prasad Eye Institute uh, in Hyderabad city, and we also visit many of the secondary centers which are associated with LV Prasad Eye Institute. And in many of the places, we have seen that there are a lot of systemic emergencies that arise during the ophthalmic procedures. So to overview, we can place them in a pre-operative model, pre-operative and peri-operative emergencies in ophthalmology, and how you have to manage. To make it in parts, the first systemic emergency what I wanted to focus was anaphylaxis, which Pushpa madam has already very nicely enlightened. It is mild, moderate, and severe. The mild one is when you give the block in that area, you may have a rash, and the moderate is the rash is throughout the body, and the severe one is apart from the rash, what you get uh, throughout the body, you may have laryngeal spasm and all. And for mild, it goes off with Avil, and for moderate, normally we use what you call it as hydrocortisone along with antihistamines, and also salbutamol. Inhalation, nebulization can be done, but for severe form, adrenaline has to be used, as she has mentioned. Normally, the dose what we prefer to give is zero point 0.3 milligrams, 1 in 1,000. That is 1 milligram has 1,000 micrograms, where we give IM. And at a end stage where it is not able to manage, we have to give a muzzle relaxant and intubate the patient, and airway management has to be done. Vasovagal attack is one of the emergencies what we come across, and this is normally with the strabismus squint surgeons whenever they are doing some surgery. Not only with that, with other procedures also, we will have this vasovagal attack. And whenever you have that, the first thing is we have to make the surgeon stop the surgeon to pull the muzzle, and later you can if you want, you can try the medications, atropine and glycopyrrolate and all. Hypertension, this is the emergency what we are facing in our institute. Maybe this may be the same in all. The normal value, I don't know if this is the parameters what every institute take. We at LVP, we take cutoff value as 160 by 90, and WHO statistics show that the number of attributed risk factors for death perioperatively throughout the world is because of the perioperative hypertension that come across. And usually this lasts for 2 to 6 hours, required rapid intervention, results in systemic vasoconstriction. Here I just have put something like a case scenario, because this is the scenario which happens regularly in our institute. A 67-year-old lady posted for retinal surgery, hypertensive, diabetic, on treatment, missed the morning dose of antihypertensive drug. Pre-operatively, BP shows 164 by 92, which is a little bit on the higher stage, but still the surgeon wanted to do the surgery. A peribulbar block was given, and during the procedure developed sudden onset of breathlessness. So when such type of scenarios come, how we have to manage is immediately immediately the patient has to be put in a comfortable position with oxygen, and then antihypertensives like labetalol or nitroglycerin can be used. And if this hypertension persists and the patient lands up in pulmonary edema, Lasix has to be used. Always remember that nitroglycerin is a better option than nitroprusside, because nitroglycerin is a vasodilator, venodilator, where the blood pressure will be falling slowly. But if at all, if any anesthesia is there, you can also use a nitroprusside. But the difficulty with nitroprusside is it is a veno and arterial dilator, and the blood pressure falls in such a drastic way. By the time you turn, the BP will be shot down. So better you stop at nitroglycerin. Most of the time, labetalol is the good drug of choice. So this type of, and we come across many of the patients of this type where they land up in pulmonary edema, where we have to use all this medication, and apart from that, CPAP, continuous positive airway pressure. It is not a mandatory that CPAP machine should be there. It's nothing but continuous positive airway pressure. You can put a tight mask with high flow oxygen of 15 liters will also be appropriate in this type of patients. I don't want to talk much about the peribulbar block as how they come. Now, the most important thing, what I wanted to talk about, cardiac arrest. Many of us still, the ophthalmologists, they feel that it is not their domain. But I request all doctors, ophthalmologists, everybody should know how to do at least the basic life support whenever a patient goes into cardiac arrest. I just have created a case scenario. A 55-year-old gentleman was given a peribulbar block in the pre-operative room, and after 15 minutes, when they wanted to shift the patient to theater, the patient did not respond. What you do? First of all, assess the response, and then you call for help, and then check the pulse. So call for help is one individual may not be able to do all the things, and if it suppose this goes for a very long time, he may become fatigued. So that is the reason always call for help. Two people will be definitely better than one person. And check the carotids. That too for you should not take more than 10 seconds to check the carotids. And chest compression has to be done in the lower half of the sternum, that is 100 to 120 compressions per minute, and 30 for every 30 compressions 2 breaths have to be given. 30 compressions 2 breaths, 30 compressions 2 breaths, 30 compressions 2 breaths, 30 compressions 2 breaths, 30 compressions 2 breaths. These are 5 cycles, and this make one round which should be done in 2 minutes. This basic thing will save the life of the individual at that particular time, because that is a patient has gone into arrest in front of you. It is a witnessed arrest. If it is delayed for 10 minutes, 15 minutes, the hopes are less. But if it is done within 2 to 3 minutes, because every 1 minute 10% of the survival will come down. So immediately if you do chest compression and give 2 breaths, then for 5 cycles, after 2 minutes, again you can check the pulse and see whether the patient has come out or not. Always call for help. Whenever you are calling for help, ask them to bring a crush cart. Crush cart is nothing but all the emergency drugs with a defibrillator and a monitor and an oxygen cylinder at the back. It's in some emergency room which comes on a wheels to the which can be dragged to the site of the patient. So whenever you are giving breaths, we as anesthetists, we say that it need not be that you should try to intubate all the patients. In an unconscious patient also, if you give good bag mask ventilation, you are almost 85% to 90% equivalent to what you are doing when you are doing endotracheal intubation. Of course, aspiration cannot be prevented with this bag mask ventilation, but a good bag mask ventilation is almost equal to endotracheal tube intubation. And bag mask ventilation, any lay person can also learn. And whenever you are calling for help, you have to ask for a crush cart, defibrillator, or at least an AED. The reason why we want AED is whenever a patient goes into cardiac arrest, there are 4 rhythms. 2 are shockable and 2 are non-shockable. The non-shockable rhythms are asystole and pulseless electrical activity. The shockable rhythms are ventricular fibrillation and ventricular tachycardia without pulse. And it is seen that 75% of the time, the patient, when he is in cardiac arrest, it is a ventricular fibrillation. That is the reason why, for example, cardiac arrest, now the impulse will generate it from SA node to the AV node. If that impulse stops and even the ventricles are not contracting, you get a flat line, that is asystole. For that, chest compression is good. It will help to revive the patient. But suppose the impulse is not generated, but the ventricles are not quiet, they will be beating abnormally. That is also not good, because the blood is not filled into the heart and nothing is pumped out. So for that, when you deliver shock, what happens is the fibrillating ventricles will calm down, and again the SO will dominate, and again the electrical impulse will start generating. That is the reason of shocking the patient. So because of that reason, what has been done is, defibrillator, a lay person, he cannot know what is the ECG, what is the asystole. So they have come out and developed equipment like what you call it as AED, automatic external defibrillator. That is just pads which can be kept on the chest. Switch on the machine will take care of it. It will inform you whether a shock is required or not. If the shock is required, just press the button. A security person is there. He will not be able to identify the ECG rhythms. So for that person, this AED will be very useful. He will be able to save the life of the patient by delivering shock. Just attach the pads, switch on the machine, attach the pads. The pads, they will analyze the rhythm, whether it is shockable, that is whether it is ventricular tachycardia or ventricular fibrillation, or non-shockable, whether it is asystole. If it is a asystole, the machine itself will tell that continue chest compression, shock not required. If it is a shockable, if it is a ventricular fibrillation, the machine says that shock required, kindly press the orange button. So it is a very useful device, and it's not that costly also. It may be 50 to 60,000 rupees now available in the market, and now the Indian versions are also coming with very cheap for 20 to 25,000. Because every small hospital, if they have that, they can save the life of the patient if the patient is having a shockable rhythm. So these are some of just the photographs of what is a shockable rhythm, and always the machines what you have, defibrillators, are all 200 joules biphasic. Biphasic is nothing but the shock is delivered in two directions. Previous machines were all monophasic. The shock was delivered in one direction, and in that the joules will be 360 joules. But what happened is, it was noticed that when so much of high energy is there is a damage of the skin and all. So they have come out from 360 joules to 200 joule biphasic, where you can deliver the shock with less joules and biphasic. All the machines which are there now, defibrillator machines, are 200 joules. And another thing is, the good thing what they are doing is, all the defibrillator machines, they are also keeping a AED mode in that defibrillator. Suppose a person is there, he doesn't know the ECG, read the ECG, he can put it on the AED mode, put the pads, and he can also give the shock with this particular defibrillator. And pharmacological management, adrenaline and amiodarone is the pharmacological management of this RS patient. Adrenaline can be given in shockable and non-shockable rhythm, but amiodarone is only given in shockable rhythms. The take-home message is, before going to this, I always tell our ophthalmologist, I don't know, ophthalmologists may be there, they may be feeling bad. I always tell the ophthalmologist that whenever they are taking a case, especially in the secondary centers where there is not much manpower, they are alone, only one doctor is there, one ophthalmologist, one anesthetist is there, one ophthalmologist there, to take, if they have good setup and everything is there, physician is there, everything is there, anesthetic machine is there, everything is okay. But if not, take ASA grade 1 and grade 2. ASA grade 1 is a patient with normal patient with no comorbidities, nothing is there. Patient is normal, BP is normal, is not a hypertensive, not a diabetic and all. For them, for us, it is graded as ASA grade 1. Grade 2 is the patient is having hypertension and diabetic, but he is under control. He is taking the daily medication, and his BP and everything is under control. His diabetic status is also under control. These two type of patients you can take. But if the patient is having a hypertension which is not controlled on the day of surgery, and diabetic which is not controlled, that will come under ASA grade 3. It is better to take it in a institute where you have a full-fledged things. If suppose the patient goes into some cardiac arrest and all, they should be able to manage. And another thing what I want to tell you about the monitors. First option is, every patient, if you can keep the basic 3 parameters, pulse oximeter which gives the saturation, we call it as a multi-para monitor. Everybody calls it a multi-para monitor. SpO2, which gives the saturation, and automatically by default you'll get the heart rate, and NIBP. BP can be measured, and also ECG. If these three parameters are there, I feel that even a ASA grade 1 patient should also have this monitor, so that if something you drape the patient and something goes wrong, it will be immediately visible onto to us when on the monitor. So these three parameters, for me it is only three parameters: SpO2, ECG, and NIBP has to be for every patient. ASA grade 1, grade 2, grade 3. The ASA grade 3 patients, apart from this, I always request our ophthalmologist to put a cannula and do the surgery, because if at all that grade 3 patient, if it lands up in problem, it will be very difficult at that particular time. He may be in collapse and the veins are not identified properly, so it may be very difficult to get the vein, and we have to shoot adrenaline or some drug to that. So that is the thing what I always give as a takeaway message. And apart from that, crush cart, you have to have a crush cart which is having all the emergency drugs with the defibrillator, or at least AED with oxygen cylinder, bag mask, ventilation mask, everything has to be there. Of course, IV. Nowadays we are getting IV lights, where especially for children, where you can visualize the thing and put a IV cannula. And always have, how small may be the hospital, always have a code blue team, mega code. That is, whenever there is a code blue, a strong person will be good to do a chest compression. So who is to be doing a chest compression whenever a patient goes into arrest? Normally the code blue team consists of 6, but 6 is a very luxury. One is for chest compression, another is for airway, third is for attaching the monitor and delivering shock, fourth is for putting a cannula and giving the medication, fifth is the team leader, and the sixth is the person who documents what is going on. Normally it is 6 people, but at least 3 people have to be there. At least 3 people have to, one for airway, one for chest compression, and one for attaching the monitor and all. So that is the code blue team, what we maintain in almost even small institute also. And everything what in our country, what we see is we do very good things or we do bad things, but we don't document. Documentation is very important. Once you document, we know how it's going on. So documentation has to be done for every thing, so that a patient safety committee and all has to be formed in the hospital. So this is the things I wanted to just mention in my lecture. Thank
you. Well, thank you, Dr. Venkat Raja. That was a very vast topic, but you have nicely condensed it in such a short time, highlighting all the important points. And now I think the session is open for discussion.
What of this machine you are talking about, automatics, is it available in the market, and who is marketing it? I'm talking about the technical marketing. What is the name of the machine? Who's marketing it? What is the cost? From where we can get it?
You have, every company has, sir. Philips has. Philips has. GE has. Every company has. Zoll has. Zoll are the king of the defibrillators. Zoll has. Every vendor who are supplying the defibrillators, they also supply the AED. But nowadays, apart in the defibrillator, I told you they are also keeping the AED mode, because it may be used by a skilled man who knows everything about ECG, used by a person who doesn't know anything about the ECG. So AED mode is also there in the defibrillator also.
The 2-in-1.
Pardon? 2-in-1.
The 2-in-1.
2-in-1. That is not 2-in-1, 3-in-1, because monitor is also there. The monitor is also there. You can see the monitor, attach the pulse oximeter, multi-para monitor, that is NIBP, everything is there, and then AED is also there. There are 2 pads.
Small pedals.
No, yeah. Normally in the Western countries, these AEDs are placed everywhere. Like
Railway here also is there. Airports, if you see here, metro stations, I am not sure, but airports have that AEDs.
We have seen it. We've seen the airports. But
And now Indian companies are also making so those chips will be cheaper because of this way.
this is 60,000 rupees.
60,000 is for some
That's
company.
also not very costly for human life.
The earlier the shock, the better.
A handpiece costs more than 3 lakhs, but we talk about 60,000 rupees. I think they should be mandatory. We should keep it.
Actually, the government should make it. It's a mandatory. Even by the government also it's mandatory. But all hospitals will not be able to afford and keep that AED. We have tried in. I also work with this 108 organization. So we also tried to keep in the malls and all. But our Indian attitude is, within 2 days we saw that that AED is missing in the mall. So it's that those things are also to be taken into consideration. Bus stops. Parks where elderly people go for walking for long. In those areas, it has to be there, busy areas. Yeah, most of the time the attender of the patient will be.
And it's portable, you can just bring it from the Philips, you should contact the Philips.
It's not just Philips, sir. I'm telling Zoll. Many companies have Neon Codon, Philips, GE. Everybody has AED. Every company has the AED. But only thing is cost maybe something beside us. और अभी हमारे पास क्या हुआ बोले तो we operate in different states. Telangana के सिवा, I mean Hyderabad. Apart from that, Gujarat. So what we are doing is the voice prompt, what the AED does, we are converting it to the regional language. For example, if it is used, because many people, if it is in English, may not be able to understand. So in Gujarat, Gujarati, Tamil Nadu, Tamil, Kerala, that every time, everywhere we are trying to.
Thank you very much.
Once you made this simulator, how you arrange the money, finance part,
Which one?
to do this research and to make the simulator?
No, you are
Money-
asking about
money-
the future.
No. If somebody wants to start making something
Simulator. Okay.
not your thing, it will be get patented, but other things. So how to start and from where the money is coming?
So for me, fortunately, IIT sponsored the whole project.
Okay.
To be honest, I was just giving them the inputs. So for me, that grant was there. That Department of Biotechnology, I think so.
So you proposed that, and then they made a protocol.
Yeah. You should
And
write a
they-
proposal and submit to the Department of Biotechnology is there. Even ICMR grant is also there. So you have to submit through Institutional Ethics Committee. Once approved, you can submit and then automatically they will see that and grant can be given.
Okay.
It's a long drawn, actually 14 years.
14 years.
2009 I started. This is where we...
Yeah. Okay, I think we have. It's 11:30.
Any other questions? Yeah, please.
Do you have any cutoff point for a diabetes? Because the diabetic patients, they say that they are like
Yeah.
normal. They are something normal. And when you tell surgery, they immediately tell that my sugar is sugar. Because as a diabetic, definitely they'll be having comorbid with the hypertension.
What we do is, we normally, apart from the diabetic status, what we do is we see the HbA1c. So if it is in the normal limits or just the borderline, we take the patient, even if it, but 200 is our cutoff. I don't know. 200 is the cutoff.
But since the patient will be like a COPD, they will take it to 100. After surgery, they never bother up the diabetic.
Even if it is a little more, and the HbA1c is within normal limits, we ask them to do it. That depends again on the surgeon, because he should be bothered more than us. We don't have any problem in giving the block or whatever it is. he should be more worried about it.
And any idea for intracameral adrenaline relation to emergencies?
Intracameral adrenaline, yeah. Jay, what is it, Joe?
Adrenaline.
There are no vessels, so the option of that is you are using only 0.1. If you use more, it will come out and then it will be absorbed. And many times they used to move in the adrenaline, and that is the rush. So if the patient is of, if I am talking about pediatric patient, if it is a heart disease patient, I usually say you can avoid it, you can use other methods, you can use it. And if the adults also, they are having CAD and other cardiac problems, I tell them that please try to avoid it. But intracameral adrenaline per se is not causing any problem. Phenylephrine is causing problems.
Atropine plus, I think that phenyl. We are actually we tell.
Yeah. Like intracameral, you can use phenocaine, just don't, or immediate dilatation.
Phenylephrine 2.5% residents think that it is safer, so they can put 10 also. So it is a pediatric one. So everyone should know that you train their trainees or nurses how to put phenylephrine. One drop you would need to put at every 1 minute. Mostly I just press the punctum. So intraoperatively, yes, we have seen many cardiac hypertension. Once intraoperatively, in the open eye, they put the one drop phenylephrine.
Standing in 1 year, I'm seeing
Check the
drugs.
check the block. People are saying yes, they will block, so the problems are more now because of that 1.5.
Nurses will keep on putting phenylephrine again and again when we say no pupil dilatation.
What happens in our institute, the patient will be a little late, and they go on putting the drops, because they're scared with the surgeon. They lost them. So many drops, they patient, many of the patients, they landed up in crisis.
That's why the dilatation protocol can be pasted on the OT area, preoperative area, and nowadays you can. There are many ways to do it. You have only one nurse to do it, and if she is not doing it properly, you place that nurse to area which wherever nobody wants to be placed, just like Kalamani.
I go retrospective and suddenly they call for increase. I asked for house dilatation. It's a medical dilatation.
So this is the perpetual problem. Someday it will be less, someday it will be more. So calling the patient well before so that they can be dilated in that time. If the patient is coming to the preoperative area 5 minutes before, they put many drops. Even you are talking about nurse, residents are not doing it. One of the patients said, I took it 10 times. Another said that I took it in second bottle to dilate. And the third one came that I also took the second bottle.